Welcome back. I'm an emergency doctor actively working at the emergency department of my hospital. In this Doctor's Corner series, we'll dive into lesser-known approaches and hidden strategies to help the people with critical illnesses. You can subscribe if you want to learn the latest news and healthy solutions about your health. Listen carefully. Creatinine is not a magic pill for nicotine addiction. Do not misunderstand it. Do not take creatinine as a smoking cessation drug. Instead, use it as something more precise, a biological anchor, a measuring tool, a quiet laboratory witness that can help turn quitting from a vague promise into a trackable medical process. Why does this matter? Because smoking addiction is not only a habit, it is a drug delivery system. Every cigarette delivers nicotine rapidly to the brain, stimulates nicotinic acetylcholine receptors, increases dopamine signaling, and teaches the brain one powerful lesson. When stress rises, when boredom appears, when coffee is poured, when anger hits, smoke. The body learns it, the brain stores it, the environment reminds it. So ask yourself, how can a person defeat something they cannot measure? Most smokers say, I'm cutting down. But what does that mean biologically? 10 cigarettes? 5? Deeper inhalation? More nicotine per cigarette? A few hidden puffs? More secondhand exposure? More vaping between cigarettes? The mouth may say one thing, but the urine often tells a cleaner story. That is where creatinine becomes useful. Creatinine is produced from muscle metabolism and removed through urine. In urine testing, it helps correct for dilution. Why is that important? Because urine concentration changes all day. Drink more water and a urine nicotine marker may look lower. Dehydrate yourself and the same marker may look higher. Without correction, the number may mislead you. With creatinine correction, the result becomes more stable. Nicotine-related biomarkers can be expressed per milligram or per gram of creatinine, giving clinicians and patients a better sense of the real exposure. Now hold on to this idea. Creatinine does not fight nicotine directly. It fights self-deception, confusion, and guesswork. And in addiction medicine, that can be powerful. Start with the biology. Nicotine itself disappears relatively quickly, but cotinine, its major metabolite, lasts longer and is widely used in medical literature to confirm tobacco exposure. Researchers such as Neil Benowitz and colleagues have described cotinine as one of the strongest biochemical markers for tobacco use and abstinence. The Society for Research on Nicotine and Tobacco has emphasized biochemical verification because self-report alone can be inaccurate, especially when shame, insurance concerns, surgery requirements, or family pressure are involved. So ask, why not simply measure cotinine by itself? Because urine is not a fixed container, it is a changing river. One person gives a concentrated sample in the morning, another gives a diluted sample after drinking water. If you compare those numbers without adjustment, you may compare hydration more than smoking. That is why creatinine correction is useful. It gives the cotinine value a reference point. Think of it this way. If cotinine is the smoke signal, creatinine tells you how thick the air was when the signal appeared. Clinical chemistry research has examined this exact issue. Jatlow, McKee, and O'Malley discussed urinary cotinine correction for creatinine in the context of smoking cessation trials. Other analytical studies using LC-MS/MS methods measured cotinine and creatinine in 24-hour urine samples from smokers and non-smokers and showed that creatinine-normalized cotinine values correlate strongly with uncorrected measures while helping account for urine dilution. That is not just laboratory trivia, that is a practical tool for people trying to quit. Now make this practical. Do not tell a smoker only, use willpower. Give them a map. Tell them, let us measure where you are, then measure where you are going. Here is how creatinine-supported monitoring can help. First, use it to establish a baseline. Before quitting, measure urinary cotinine corrected to creatinine. If possible, measure other tobacco biomarkers as well, such as NNAL, a metabolite connected to tobacco-specific nitrosamine exposure. Why? Because cigarettes are not only nicotine, They carry combustion products, carcinogens, oxidants, and inflammatory triggers. A smoker may think, I only smoke half a pack, but biomarkers may show heavy internal exposure because of inhalation depth, cigarette design, metabolism, or dual use with vaping or smokeless products. Second, use the numbers to break denial. Say this clearly, do not argue with your craving, check the data. Addiction loves fog. It says, one cigarette does not matter. It says, I barely smoked this week. It says, I'm doing better, so I don't need treatment. But creatinine-corrected testing can show whether exposure is truly falling. Why is this helpful emotionally? Because quitting smoking is full of invisible progress. The lungs may still cough, sleep may be disturbed, irritability may rise. The person may feel worse before feeling better. But when the urinary cotinine to creatinine ratio drops, the patient sees evidence. My body is clearing this. That creates momentum. Third, use creatinine correction to protect the patient from false reassurance. Suppose someone drinks a lot of water before a urine test. The cotinine concentration may fall simply because the urine is dilute. But when cotinine is interpreted with creatinine, the clinician can better judge whether the change reflects reduced nicotine exposure or just hydration. How does this help? It makes the quit plan harder to manipulate and easier to trust. Fourth, pair the measurement with evidence-based treatment. Do not use creatinine alone. Combine it with what has been repeatedly supported, counseling plus medication. The US Surgeon General's report on smoking cessation, CDC clinical guidance, USPSTF recommendations, and multiple systematic reviews all point in the same direction. Behavioral support and FDA-approved pharmacotherapy improve quit rates, and using them together works better than either one alone, so give the patient instructions. Set a quit date. Remove cigarettes, lighters, ashtrays, and emergency packs. Tell the household, do not offer me cigarettes, do not smoke near me, do not negotiate with my craving. Then choose medication with a clinician. Consider nicotine replacement therapy, such as a patch for steady coverage plus gum or lozenge for breakthrough cravings. Consider varenicline or bupropion when appropriate. Screen for pregnancy, psychiatric history, seizure risk, kidney disease, drug interactions, and personal preference. Do this properly. Do not improvise with addiction. Now ask, how does creatinine fit into this treatment plan? Use it as a feedback loop. At week 0, measure baseline urinary cotinine corrected to creatinine. At 2 weeks, repeat. At 4 to 8 weeks, repeat again. If the number falls sharply, reinforce the plan. Keep going. Your biology is moving in the right direction. If the number remains high, do not shame the patient. Investigate. Ask, are you smoking secretly? Are you vaping? Are you using nicotine pouches? Are you around heavy smoke at home? Are you using nicotine replacement correctly? Then adjust. This is where the approach becomes deeply useful. It changes the conversation from moral judgment to clinical problem solving. Do not say, you failed. Say, the exposure marker did not fall enough. Why? How do we repair the plan? Maybe the patch dose is too low. Increase support under medical guidance. Maybe the patient smokes first thing in the morning, a marker of high dependence. Add short-acting nicotine replacement for morning cravings. Maybe stress after dinner is the main trigger. Build a replacement ritual. Stand up, brush teeth, walk for 5 minutes, call someone, drink water, use prescribed gum or lozenge correctly. Maybe alcohol reactivates smoking. Tell the patient, avoid alcohol for the first month. Protect the quit attempt like a healing wound. Now talk about NNAL and creatinine together, because this adds another layer. Cotinine drops relatively quickly after stopping nicotine exposure. NNAL falls more slowly. In smoking cessation studies, urinary nicotine and cotinine can fall dramatically within weeks, while NNAL declines more gradually because of its longer persistence. One study following participants in a quit smoking program showed major reductions in urinary nicotine and cotinine after quitting, while NNAL remained detectable longer and declined over time. Why does that matter? because the body has short memories and long memories. Cotinine tells you about recent nicotine exposure. NNAL tells a longer story about tobacco carcinogen burden. So command the audience, do not measure only craving, measure exposure. Do not measure only intention, measure change. Do not measure only cigarettes per day, measure the body's chemical response. But be careful, creatinine correction has limits. Do not use it blindly in people with significant kidney disease, severe muscle wasting, very high muscle mass, pregnancy-related physiologic changes, or conditions that alter creatinine excretion. Interpret results with a clinician. A very low or very high urine creatinine can make the sample difficult to interpret. Also remember, if a patient uses nicotine replacement therapy, cotinine may remain positive because the body converts therapeutic nicotine into cotinine. In that setting, cotinine confirms nicotine exposure, not necessarily cigarette smoking. If the question is tobacco use versus nicotine medication, clinicians may use additional markers such as anabasine or NAL. Why mention this? Because precision matters. A tool used badly becomes confusion. A tool used well becomes guidance. Now bring it back to the person trying to quit. Imagine someone named Daniel. He smokes 15 cigarettes a day. He says he wants to stop because his daughter complains about the smell. He has tried twice before. Both times he lasted 3 days. This time, instead of only saying, "Try harder," we say, "Let us build a medical plan." We check baseline cotinine corrected to creatinine. We start a patch plus lozenge with counselling. We identify his danger times, morning coffee, driving, and after meals. We give commands, change the coffee location, clean the car, remove the lighter, walk immediately after dinner, use the lozenge before the craving peaks, not after it has already taken control. We repeat the urine test after 2 weeks. The corrected marker falls. Daniel sees proof. His daughter notices the smell is gone. His cough is still there, but now he believes the process. That belief matters. Why? Because addiction attacks belief before it attacks behavior. It whispers, "Nothing is changing." A biomarker can answer, "Something is changing." That answer can keep a person in treatment. This is also helpful for clinicians. Creatinine-corrected biomarkers can identify discordance. The patient reports abstinence, but exposure remains high. Instead of accusing them, ask better questions. How often are you around smoke? Are you using a vape? Are you sharing nicotine pouches? Are you using cigars on weekends? Are you taking nicotine medicine? This improves care. For public health, these measures also matter. Research studies use biochemical verification to know whether interventions truly work. Without it, quit rates may be inflated. With it, clinical trials become cleaner and recommendations become stronger. That is one reason modern tobacco research pays close attention to cotinine, creatinine correction, NaNL, carbon monoxide, and other biomarkers. Now make the method simple. Use this 5-step plan. 1. Assess dependence. Ask, how soon after waking do you smoke? If it is within 30 minutes, treat dependence seriously. 2. Select evidence-based support. Use counseling plus medication when appropriate. Do not rely on motivation alone. 3. Measure baseline exposure. Use urinary cotinine corrected to creatinine when available, and consider additional biomarkers when the clinical question requires it. 4. Repeat and respond. If markers fall, reinforce. If they do not, adjust treatment. Do not abandon the patient. 5. Protect recovery. Keep follow-up beyond the first week. The first week is not the finish line. It is the door. So what is the real value of creatinine in smoking addiction? It gives structure to a chaotic fight. It turns urine testing into a clearer signal. It helps correct for dilution. It strengthens biomarker interpretation. It makes progress visible. It supports honesty without humiliation. It helps clinicians adjust treatment instead of guessing. And when paired with counseling, medication, and a serious quit plan, it can become part of a powerful system for recovery. Remember this final message. Creatinine does not remove nicotine from the brain. It helps reveal the truth while the treatment removes the dependence. Use it as a compass, not as the journey itself. Tell the smoker, do not quit in the dark. Measure, plan, treat, repeat, and stay connected. Thank you, my friends. Take care of yourselves and each other like family, and I'll see you in the next topic.